So today we're going to talk about, I know the series has been about AI, so I don't want to reinvent the wheel in any way, but I do want to talk a little bit about kind of some of the unintended consequences of using particularly generative AI, large language models within primary care, and some of the impacts that it has on our delivery systems. So always start with objectives, I've been told. So we'll talk a little bit about a couple of, kind of three main uses that I see really prevalent in primary care and kind of go through, be able to characterize those different uses. And then a little bit of the foundation work, though I know that many of you have already had AI 101 kind of talks, so we'll go through that pretty quickly. We'll then have you or at the end of this talk, you should be able to compose a list of concerns relevant to AI in both the clinical and educational setting, and then design your own workflow for the responsible use of AI and kind of be able to pilot what you think is going to work the best for you. So my first here is disclosure that I used KUMC's Copilot, which is a form of AI that we'll talk about, to outline this presentation. And I thought it did a pretty good job, but as always, had a lot of work to do after kind of getting an outline. So why these risks matter. Many of you are probably already seeing integration in your own spaces of AI. And so there are a lot of incredible benefits. It has revolutionized my life, particularly ambient AI use, but there are some serious risks and some unintended consequences. So first of all, the pace is incredible, more than the pace of development in the Industrial Revolution and other large kind of technological shifts. There's a lot of data to support that LLMs are being so quickly adopted within and without the healthcare space, and are often already kind of integrated in primary care now, without kind of due process in terms of regulatory assessment. So it comes down to the health system, but also ultimately the individual's understanding of liability, to make sure that we understand these risks and are making sure not just to safeguard against those risks, but also to disclose to the people who could be affected. There are some risks to patient safety and equity that we're going to talk a little bit more about. Several of these sources, but these are just the very tip of the iceberg, I feel, in terms of the literature that's coming out about unsupervised AI use, how it can impact diagnostic accuracy, medication safety, health equity, and then erode patient trust. In terms of primary care, right, it's terribly complex what we do, and a lot of time our care is based on evidence, but is not completely algorithmic, or we're trained to take into account a variety of aspects of our patients' illnesses. And so as you have more continuous relationships, you have more complex diagnoses, how the large language models are able to do that, and then if they're able to provide the proof to you that they've considered all of those things, is still pretty nebulous in the tools that we have. And finally, there are some implications in terms of liability that need to be considered for using AI use, for AI use in a variety of ways. And so we'll talk through a little bit more of these. I think it's really important. As a family physician, I think that primary care physicians should be at the table for these discussions in our organizations. I think we're well equipped for several reasons. First of all, our continuous and personal connection with the patients and their values. I think we are often really good and passionate patient advocates. I'll also say I think that patients and patient representatives need to be at the table for these discussions as we start to integrate these more. We also bear an unequal burden of documentation and metric measurements within the healthcare delivery system in the United States. And a lot of these tools that are being developed, if they're developed without a primary care lens, they actually could become more burdensome, rather than serving us in a way that is both accurate and actually helpful. And then finally, um, when we think about how notes are used in our system, so thinking more about ambient AI, kind of ambient dictation, tools like Abridge and DAX and things like that, it is obviously paramount that those be accurate, that they be timely, because not only are our other healthcare colleagues and our future selves using those, but obviously our patients have access to those as well. And so there's a real risk for error if we're not taking safeguards. Um, so I think another issue that's interesting, I was at a AAMC meeting last week, and one of the things we talked a lot is physician wellness. And so this ambient AI, and isn't it going to make us all so much more well? And I would argue that it absolutely can. But there are some other stakeholders within the healthcare delivery system that may have some competing priorities. So is this used to augment our wellness? Is this used to achieve speed for the process, to have us see more patients? When I was reviewing one of the early ambient dictation tools several years ago, on one of the surveys I was asked, so how many more patients do you think you could see? And so again, I think it's critical that we're at the table as family and other primary care physicians, and practitioners, to say, hey, this is moving the needle in a really positive way. But we've got to safeguard against some of the other ways that this technology could be used. It could be, frankly, it could be exploitative if we're not involved. So again, I anticipate many of you have been party to, if you're at this talk, may have been party to the other talks, and may have already seen a lot of this. So just briefly, the nature of large language models that are AI based. So essentially, to break it down in a way that I think my colleague, Dr. Parente, would probably think is way too simplistic, but ultimately, it's kind of a fancy word calculator. So it's very fancy, it's very complex, but it is not a truly, neural network. It does not understand your content or your intent. It has extensive training data, but it's predicting the next best word, the next best phrase, based on machine learning mechanisms. So they do have limitations in the clinical context, right? So they do not have clinical reasoning skills. They do not have verified knowledge. So they are not substitutes for medical judgment. And depending on the data with which they're indexed, or the data on which the large language model is trained, gives it some ability sometimes to reference its source material. But we've seen in multiple kind of journal articles that it's not even that great at interpreting a lot of medical literature just yet. It is getting better, but there are still inferences made that are inappropriate, and it may apply a population level type statistic to your individual patient, misinterpreting that information. And so it can come alongside us in medical judgment, but it is not overall it does not have medical judgment. It's not had the training that we've had. And then finally, they are very authoritative. The large language model, what they give to you is never going to say, I don't know. It's never going to say, I'm not sure. It's never going to give you like a plausibility index, at least so far. It may be fabricating. It may be, we'll talk about hallucinations, but it's important to know that it will never give you a null output. And it will never say, I can't find anything to support what you're saying. You can ask it to prove anything, and it will come up with an answer for you. So I want you to bear those things in mind as we move forward. A little bit of vocabulary and some variations. So when we think about large language models that are AI driven, I think in three contexts at this moment and how it applies to my life. So one is ambient dictation, brand names of this, right? DAX, Abridge, Doximity, Open Evidence. There are paid versions, there are free versions, ambient dictation. Next is kind of generative AI. So these are the engines that are all, and some of these are based on different algorithms, but will give you that um, person-like output. So there's Claude, obviously, ChatGPT, Copilot, and then Google's is Gemini. Importantly, Microsoft is Copilot. But importantly, all four of these at least have different parent companies, and will give you slightly different outputs. Claude is probably the most anthropomorphic in a way. And then ChatGPT, obviously, very popular use. And then, like I say, Copilot, KUMC is partnered with Microsoft to have a Copilot version, if you're logged in, that is behind a firewall. And then Gemini is the Google feature. Third, I think about the clinical evidence support that we have. So these would be things that are large language models, but they're directly indexed or trained on a discrete source of data. Open evidence tied with NEJM, JAMA, NIH, and PubMed indexed articles. Though again, there can still be some issues within there. One interesting differentiation between some of the more general AI, generative AI models and like clinical evidence support, like open evidence, is that open evidence will give you sources. Now, it may misinterpret those sources and occasionally may hallucinate a source, but should be able to trace your work back. Claude, Chat, Copilot, and Gemini are really this black box, if you will, of where the information comes from. So, one discrete thing that AI can do that poses a threat in terms of our use, well, all of our uses, I'll show you in a minute, but is hallucinations. So definition is that this can produce a false or fabricated information, but again, it appears completely confident and fluent, which is, as those of you who work with trainees, sometimes those are the scariest trainees, the ones that are the most confident, and you're like, wow, you're like really confidently wrong, and so you kind of have to balance that out. Well, this is always going to look confident, and so hallucinations, again, examples include fake citations, incorrect clinical trials, unsafe medication, or even behavioral health advice posing serious risks. And the tricky thing is, we're not excellent at finding hallucinations because the hallucinations, often on first glance, seem to have plausible medical narratives, and it does make detection difficult. And so we'll look at that in just a second. We can verify, but there's some research out there to say that even if we're aware that it can hallucinate and we're trying to detect it, we're not actually excellent at this as humans overall in study populations. So just awareness of hallucinations may not be quite enough. So how do we mitigate this? So one thing is, if you're using generative AI in terms of like Claude, Chat, Copilot, prompt engineering becomes really important. If you're asking it to outline a PowerPoint or to provide you, say provide your sources and things like that. So those prompt engineering, some other methods can reduce hallucinations but cannot eliminate them. So you do have to obviously still have careful human oversight. An interesting article from 2023 I came across in looking at this talk was talking about how we talk about these hallucinations within AI, and that's the word that we use, but kind of like challenging that as a word. So are we further stigmatizing humans who have hallucinations or see things or hear things that aren't there? Are we further are we creating more bias against humans that have hallucinations by using this in our vocabulary? So should we call them medical misinformation? And so I'll leave that nugget of thought with you. I do think how we use our vocabulary really matters. So I won't debate that back and forth, but we'll leave you with that in this article here if you'd like to take a deeper look. The next thing that I just am constantly entertained by, but is AI generated images. And so I've got a couple of examples here that it's just incredible. that people post these without oversight. But you can ask AI, generative AI, to generate an image of literally anything. And sometimes they're funny, and sometimes they're okay, and sometimes they really do, they really can. Um, generate a lot of medical misinformation. These were both, so the one of the knee, I think is interesting. I don't know what a medial lateral dimension is, but I know that that's not what that is. I'm not 100% sure all the things that are coming off the femur there. And I know that the patella is not a part of the proximal calf. And so you can also see the misspellings, but it looks, to an untrained eye, it might look as a really detailed anatomical image, but as Dr. Templeton can tell us, that's not quite where things go. And then I saw this one actually on Facebook last night, but understanding back labor, but these pictures make no sense. So the first thing, right, that it says is baby is head down, and this baby is clearly not head down. And the baby is not in different positions. It's not showing anything. I'm also not sure what's wrong with the baby's nose. But it really explains nothing on back labor or why it would look like that. Uh, so anyway, just to say these images are out there. They're also very widely available, like on social media and things like that, and maybe perpetuating medical misinformation, which is good for us to be aware of. Okay, so back to these hallucinations or AI misinformation. They can cause obviously incorrect diagnoses, anchoring clinicians, also the bias of early closure, delaying correct evaluation, especially I think as they get integrated closer and closer to the point of contact with the patient. And so now I work with a bridge here on the KU campus, and it even today was suggesting questions that I ask open evidence through a bridge during the encounter. And it's like, I need to think through this first. Medication safety hazards. So again, we can use, we've got excellent cross-references for medication interactions and things like that. But it may make recommendations or suggest doses or things like that that are not correct or may not be ideal for your patient. And also, again, thinking about the amount of information that's available to our patients. So patients also will ask, right, ChatGPT or whatever their LLM of choice is, and it may provide them misinformation as well. And then impact obviously on patient education. There's some really scary literature in terms of like behavioral health interventions and some of these engines that are acting as therapists and things like that, obviously can suggest things that are very unsafe. There's also an unequal distribution of hallucinations. So they're more common in the medical side for rare diseases, marginalized populations, data training gaps. Again, this is where it's never going to tell you I don't know. And so it's going to fabricate more when it has less data to index it on. But again, it's all in this black box. It's all really kind of opaque for most of these models in terms of how those networks are connecting the words that you get that look like a very plausible sentence. So the further out it is, the further from your prompt, the further from kind of widely available medical literature, the more likely you are to see hallucinations. Again, it's never going to say, I don't know. I asked, or sorry, I'll come to this study first from JAMA in 2023. So this was really interesting. The study design was a randomized clinical vignette survey, and they wanted to evaluate the impact of AI models to determine if an image-based AI model explanation would mitigate model errors. So basically, they built a standard model and then a systematically biased model. So a model that would like intentionally give you the wrong answers. And so they took 457 clinicians, both physician and NP. And then as you can see of their baseline, the standard model um, did improve diagnostic accuracy. I believe it was some different image models on CHF, pneumonia, differentiating between cardiopulmonary diseases. So the standard model helped a little bit in terms of the clinician's diagnostic support. The standard model plus explanations of where that came from, how that was generated, helped even more to increase diagnostic accuracy. However, the systematically biased model made clinicians less likely to get the accurate diagnosis, and that was not mitigated fully by the explanations that were given. And so essentially, even though they even though they explained and gave this wrong explanation, that still didn't sway the clinicians. So just to say, in favor of diagnostic support, in favor of explanations, but where those hallucinations, those errors are happening, not even explaining wrong science was able to sway the clinician. So it's really important that we are really intentional about how things are indexed, how the model is built, and then try to mitigate bias at literally every point, which Dr. Templeton will talk about as well. I wanted to share with you all a little bit, if you're thinking about this generative AI, having AI write you the outline of a presentation and write you the outline of a letter, because I know we all use these for various things, for PA, for prior authorization letters or letters of recommendation and things like that. So I wanted to show you the value of a clean prompt. I asked ChatGPT last year to design an invitation for my daughter's birthday party. We were going to Deanna Rose, and so it goes from left to right. So the first one, that was its first go at the prompt, and I was very specific with the prompt and the design, and I thought that was really cute. But my daughter has blonde hair, so all I asked it was make the child blonde. And that was the only kind of redirection I used. And so it came up with the middle image. And I thought that was really cute. Got a little up close on the animals. The animals all still look okay. The little girl is blonde. But it still looked a little wordy to me. And then it had Deanna Rose in OVDK, which I think was trying to say Overland Park, or trying to abbreviate Overland Park, Kansas, but I didn't like that. So then I asked it to only change Overland Park, Kansas. And then it came up with this last one on the right. And so it misspelled my last name. It misspelled her last name. It put a random time after my phone number, which is fair. Like, you probably shouldn't call me after 9 o'clock to RSVP for a 4-year-old's birthday party. But then it messed up the initials after the time. It put my daughter's feet under her knees instead of at the end of her legs. It put her in a kimono, which is interesting, but I feel like most importantly, it looks like the piglet is now having a stroke. And so that to say that had gotten too far from the prompt, and ChatGPT really loses, I don't want to call it necessarily concentration, but it kind of loses the sight of the first prompt the further you get from the prompt, and is unable to make those kind of small tweaks. So I ended up starting over with a new prompt and made it more simple, closed my browser, cleared my cookies, and asked it kind of a similar prompt, but added blonde child, and got here to this image on the left, which was really fine, except the mane of the horse is a ponytail, and I'm not sure where the body of the horse is, but I wasn't too worried about that. So honestly, instead of putting it in again, I just got on Paint and kind of tried to fix the horse's mane, which wasn't perfect, but it was still there. So that was my fun adventure using ChatGPT, even just to make a party invitation. So clean up your prompt. Restart, you can keep the prompt that you ended up with, but close all the way out of the browser, clear your cookies, and then go into the engine again. And I think you'll have a much better time using that generative AI. So we'll talk a little about bias, and then Dr. Templeton's going to share on bias as well. The source of bias, as we said, it can come in at any point in the development of the large language model through prompt generation, through the interpretation of how it's interpreting your prompt, and then through your even all the way through the output. And so when we're looking at mitigating sources of bias in large language models, we really have to look at all of those levels. Certainly, if it's indexed on racist, biased, any ism type of literature, which obviously appears in medical literature as well, those recommendations that are going to come out of that are also going to be representative of the same bias. It is not adept in mitigating bias. And again, it's hard to detect because it functions as this black box. You put your prompt in, the data is indexed, the engine is built, you put the prompt in, and so it's really hard to get to the source of bias and to try to mitigate that within the process. And then finally, kind of uncritical use of that biased AI information carries serious risks, right, of perpetuating social and health inequities that we aim to reduce. And so it's definitely not a tool to mitigate bias. In fact, it can perpetuate and amplify bias, which is something we all need to be really aware of. It also can have some equity issues that we'll talk about, and this can be in a variety of different spaces as well. So there are some risks in patient communication. So language mismatches and AI tools can create culturally inappropriate or complex materials. We all know that we have like limited health literacy. You can ask for it to produce a flyer on or a patient education on mild cognitive impairment. But without reading that, just giving that straight to the patient, you risk kind of giving too much material, giving incorrect material, giving biased material, or too complex material. Even if you add in your prompt, at a third grade reading level, at a fifth grade, eighth grade reading level, it still may misinterpret that. It may not be appropriate information. Finally, or not finally, but there's also an influence on how we perceive the differential framing. So as we come to use these tools more, it can impact our judgment, impact our diagnoses and treatment decisions. Again, because of those. Because the data that's coming in may not truly represent our patient population. Again, there's an unequal distribution of error, and this has to do with the data that is indexed. And so it disproportionately affects marginalized groups, which potentially could increase healthcare disparities, which obviously is not something that we want to invest in. And so we have to have an equity lens. Everything that we produce, every note that we write with ambient AI, everything that we generate, we need to make sure that we are evaluating not just the safety, the usefulness, but also the equity risks that some of this technology brings in. And again, it can be subtle, it can be difficult to detect. So I'll hand it over now to Dr. Templeton.
Thank you so much. That was a great presentation, and then we will get back to you after my presentation. I'm just going to talk a little bit more about biases in AI. As Dr. Rampon was mentioning, there's a risk that AI could actually further some of the biases that we already see within the literature and within research in healthcare. One of the main issues is that AI relies on data, but I think it's important to understand which data. Underrepresentation of groups of people in research and in published research, or in the data sets that are utilized to train AI, can really change and cause some negative impact from if you're going to implement then the output that you get from AI. This is an issue if we're trying to look at AI as a way to lead to more personalized care, but also when we're trying to deal with things like hallucinations and how AI could potentially exacerbate biases. And these are underrepresentations of groups, whether it's based on sex or race or disability status, anything where you don't have a population included in the data that reflects the population that you're seeing in your practice. So I'm going to talk about sex-based differences just as an example, example where we could potentially run into trouble. We know that there's sex-based differences in every health condition that's been looked at, and that's part of the issue is that research hasn't consistently looked at sex-based differences. But these differences are based on differences in anatomy, physiology, local and systemic impacts of sex hormones, and importantly, I think differences in pharmacokinetics and pharmacodynamics. There are sex-based differences in drug absorption and bioavailability, and actually 8 out of the 10 most recent drugs that have been removed from the market have been removed because of unanticipated unintended side effects among women. Well, if we're looking at AI to look at medication prescribing or medication recommendations, is the data available to AI to understand that there are issues with medication safety? Is that potentially going to lead to issues with dosing? So there are lots of issues that we can see because of what is or is not in the data. You can see from the types of conditions that are on the screen where we see there are differences in types of lung cancer. Women are more likely than men to develop lung cancer as a non-smoker. Well, if we're screening people for lung cancer, is that taken into account? Colon cancer, different location of colon cancer usually, or it's more likely to be in the ascending colon among women. Differences in pain. Women have more chronic pain than do men, are more likely to have acute translating into or extending into chronic pain. Does AI take that into account if we're treating a patient with pain? Is there awareness as it's going through the algorithm that women's pain is just different and there are different driving factors? We also know that there are significant differences in heart disease. Women tend to present with different symptoms from heart disease than do men. That makes it harder to diagnose myocardial infarction in women, meaning that their in hospital mortality tends to be higher because it comes to a later diagnosis. Next slide, please. And so just focusing on that last point of women presenting with different symptoms, again, they have worse outcomes than do men. Because they're usually diagnosed as chest pain of uncertain cause. But despite knowing that, if you look at the data, there was a clinical practice guideline on myocardial infarction. On average, the studies included in the guideline contained a population that was 25% women, and only 10% of the included studies in the guideline disaggregated data based on sex, which means that if you're looking at a guideline, if so few women are included and we don't look at the data based on sex, it's hard to know in whom you're going to use the recommendations of the guideline. Well, if AI is looking at the literature and is looking at guidelines, is it going to help you in a decision-making process if the data on which it's based is going to be biased? Next slide, please. And so what do other studies tell us about inclusion of sex? This is just a one-off in terms of cardiology, and it isn't. If you look across the literature, about 30% of published studies that address a condition experienced by both women and men will include a mention of women or disaggregation of data based on sex. This includes my own field of orthopedic surgery. If it doesn't often look at impact of sex, but for those few studies in the study that did, a third showed a difference based on sex. So we know that sex makes a difference. But if the data isn't out there and the data in which we're training AI isn't out there, what are we going to run into in terms of potential hallucinations? As Dr. Rampon mentioned, AI is never going to tell you that it doesn't know. It will come up with something, but if we don't have adequate data, what is that something that it's telling us? Next slide, please. So do large language models or other forms of AI reinforce the biases that are out there? This was a study in which they used cases that have been published in New England Journal of Medicine as very basic teaching cases. And in those cases, the author just switched the sex of the patient that was discussed in those cases. And so the higher the rank, the less concerning the condition is. And so if you look at the picture or the graph on the top right, looking at panic and anxiety disorders, the AI gave you the output that that's more important in women than it is in men. Well, that discounts mental health disorders in men, assuming that a woman is more likely to have an anxiety or a panic disorder. On the other hand, acute coronary syndrome was the least likely concern that this model told them that this is using Chat GPT. This is acute coronary syndrome was the least concerning condition among women, much more concerning among men. Well, as we talked in the previous slides, cardiac disease is actually a huge issue among women. But if this GPT model is going to tell you that it's nothing to be concerned about, that's something that we have to filter through our own knowledge base and understand that that's actually not appropriate. So again, the training initially of these models is based on the literature and then on data sets. The literature can be biased because of underrepresentation or lack of disaggregation. So does that then reinforce these biases when we're using them to train AI models? So are the algorithms trained on an inclusive data set? This can overestimate the prevalence of conditions or underestimate them in some, and can lead to confirmation bias, meaning AI is telling us what we already thought was true, but that's really not necessarily how we want to use AI. On the picture on the bottom, this was the same study in which they're looking at which conditions are more important in women versus men. They gave this a scenario of someone presenting to an emergency department with acute dyspnea. The pink is more important, the blue is less important. So you can see on the bottom, it shows the men are on the right, the women are on the left. Again, the Chat GPT said in the scenario of acute shortness of breath among men, that's more likely to be acute coronary syndrome. And in women, the more common conditions are going to be panic and anxiety. So perpetuating some of the biases that women are more likely to have mental health conditions, women are more likely to have cardiac disease, which if you reverse, actually decreases the outcomes for both women and men. Next slide, please. So where can bias enter AI? Again, it comes from the literature, it comes from the training data. So the training data is used to train the algorithm. If there are skewed data sets, meaning that there is predominantly one sex or the other, or the data isn't disaggregated by sex, the model on which you're training AI could potentially lead to issues and increased biases. The test data. So once you have the algorithm, you then test the algorithm. If there's skew in the data that's presented to that, again, in the patient population that's being utilized, that's going to change how the model performs. And on the input variables. So if there are different distributions of information in the variables that are input, that's going to change what we get in terms of output, all of which can then lead to bias in the analysis, whether it's bias from what the AI model is recommending, or or indicating is a potential risk for a health condition or a diagnosis of a health condition, but also the confirmation bias that we have if what we're getting out from our AI model is just reinforcing what we already knew, which may be right, but it's understanding that healthcare professionals are learning on the same inadequate or incomplete database. So we may be sharing the same biases as our AI model. Next slide, please. So a few examples of where this can be an issue. Liver disease, more common in men than women. Women tend to have a better course early on, but have more severe disease later on, which is an indication that maybe we need to be picking this up early. This, like cardiac disease, is another instance where women have different presenting symptoms. Does that then make it harder to make a diagnosis, whether we're making the diagnosis or we're putting some of the symptoms into an AI model? We've also found that there are that a result of testing and identifying liver disease is different in women than it is in men, that there are different cutoff values that we likely should be using for women. There are probably different tests that are more important than women than in men. But unless that data is part of what we're using to train the AI model, women are at risk of being underdiagnosed with liver disease and men potentially being overdiagnosed with liver disease. So it's understanding the biases of the data that are being used and hopefully working further upstream so we can use a more inclusive database to train our AI algorithms. Next slide, please. Another area where there have been some issues that have been found using a musculoskeletal ultrasound for early detection or assessment of joints. AI has been found to be really good at detecting subtle changes, but there are differences in anatomy between women and men, which can change the results of the output if you're using AI to evaluate ultrasound. And so, unless you're including an adequate number of women and men in the training model and in the testing model, AI may be missing some of the subtle changes that you're picking up with using AI when you're using ultrasound. In this study, they used either only female data or only male data or mixed male and female data, and then assessed its accuracy in looking at joint ultrasound. Not surprisingly, the AI model that had been trained with the data set that had both women and male and female data did a better job and was more accurate than one that was trained on one or the other. Again, indicating we need to make sure that we're using a complete data set, but we need to be aware of how the AI algorithms are being developed to know whether or not they have a complete data set. Next slide, please. So our studies of AI actually looking for biases. This was a systematic review of 52 studies to look at using AI, the diagnosis of rheumatoid arthritis, understanding that this is much more common among women than in men. Most studies had a female skew, which is anticipated based on the patient population involved. But none of the papers mention the issue of sex bias in the training or data sets. And that's of concern because are we then missing this diagnosis among men? There were 6 at least that mentioned potential sex biases, and only 3 out of 52 disaggregated the results of the data that was put in as a training model. And so again, it's understanding that that we need to be clear on the evidence and the data that's being used to train the models that we're utilizing. And if the training data sets in the literature don't reflect the patients that we're seeing in the office, we need to be cautious of the results that we're getting from AI because those could just be perpetuating the biases that are already in the data and already in the literature. Or on the other hand, something even worse that we we're given hallucinations because the data doesn't exist. So thank you. I'll turn this back over to Dr. Rampon.
Thank you for those wonderful examples. I want to give us time for questions, so I'd just like to bring your attention to a couple of things here towards the end of our time together. So as we talked about, just a couple of other cautionary tales from the literature, but automation bias is something to think about. So when we over rely on AI systems, even when errors or conflicting information exists, that we believe the AI because surely it must know something, it must have gotten this from somewhere that we can't see. And so we want to be careful about that. We talked a lot about bias, talked some about over reliance. And so I would just implore you to to either mildly or moderately trust AI, right? So even moderate trust in AI can distort our decision making when they're defaulted or when they're presented early, again, before you've gone through your clinical judgment process. I think this is particularly dangerous in our learners that may skip steps, right? So developmentally, they need to learn to write a note, they need to learn clinical reasoning, and AI cannot teach them clinical reasoning. And so any level of learner can suffer from that erosion of rigor of those practicing those key skills as they work with us, generating differential diagnoses, again, especially when a differential is presented early by an AI tool. And then we want to empower all of our trainees to have sound documentation skills completely on their own. And so in my clerkship, I ask that our students overall not use ambient dictation or use it very sparingly because I need them to generate their own thought processes. And there should be an upcoming article in the Journal of Family Medicine kind of talking about some of these risks and benefits. Finally, there are some issues in terms of the opacity that we talked about with the AI models, and then the lack of explainability. So I would say, know which model you're using, know where the information is indexed and how it was sourced, and then click those links, right? Even when we open something in UpToDate, we can believe UpToDate, they're well-written articles, but you want to just click that link and just go to that primary paper if you've got time, or take time to do that, right, to verify that you're using the right evidence for the right patient. It's the same thing with AI. The real risk is when it doesn't give you that tiny little number that's a hot link that's, you can go straight to the source, find that, and make sure that it's a real paper. Make sure that it's talking about what your data source is thinking that you're talking about. Finally, privacy, HIPAA, and legal risk. So as everyone is aware, or I hope everyone is aware, it does introduce some privacy risks when patient data is shared outside of HIPAA covered workflows, and can be and may be retained without transparency. There's also those of us that work in education and are transmitting educational materials. There's FERPA risks as well in terms of student privacy. And so despite disclosure, despite some of these things, you want to make sure when you need to be behind a firewall, you are behind a firewall, and not sharing any patient identified data that would implicate HIPAA, or student data that would implicate FERPA, or any of the other issues. So despite AI involvement, no dot phrase can save you in terms of if you're using ambient dictation and there's an error and it's not corrected, that is official medical documentation. Putting at the end of your note that this was generated with DAX, or there may be errors, or this was dictation, that does not release you from malpractice liability in terms of if that incorrect information is used. Interestingly, Dr. Templeton brought to my attention this week a recent litigation that's filed in California, where patient plaintiffs are alleging that two distinct hospital systems and their physicians failed to disclose the use of AI ambient dictation. There's not been a verdict, but charges have been filed in terms of they did not disclose that they were using AI. And so all of the transparency part of it is obviously really important. So you want to make sure that whichever organization you're with, that you're following those things. And then personally, I still like to consent folks to say, hey, my phone is out. I'm using Abridge today. It helps me write my notes. It's all encrypted end to end. Do you have any concerns about that? It takes about 10 seconds, and I've literally never had anyone say no. They're all interested in me getting home earlier. So, we'll go ahead and just go through this because I feel like it's still really most of the same things. I'll share very briefly just best practices in terms of working with learners. So think about where your learners are. Think about if you're getting your learners from different institutions, do they have an AI policy? Want it to be used in alignment with those institutional policies. And then think about the skills that you want your students to develop, and whether any AI tools are going to augment that experience or could be shortcutting that experience. And then we need to teach it as well, right? So using it alongside your students can also be a lovely way. One of the things I like to do is go into the room together, and the student talks and Abridge writes the note, and I observe, and I'm really able to use some of that cognitive load that I would have been using to write the note to observe the learner and make the patient diagnosis. And that can be a really lovely way to give that like direct feedback to the learners. And then we want to be role modeling, right? Excellent responsible use. So source verification, proofreading, overall accuracy. And again, I think there will be some emerging literature within the medical education space, which admittedly is somewhat lacking, in my opinion, in terms of best practices. So that is what I have. I wonder if anyone, I know we're close on time, but happy to answer any questions.
That was amazing, Dr. Rimpon. I appreciate all of the wonderful points from your talk. We do have a question about using AI for prior authorizations. Is this for medications or procedures? How are you doing it, and what AI tool are you using?
I have had a nurse bring to me a letter, like an appeal letter from a prior authorization that had been denied, that she had outlined and generated with open evidence, and then my nurse had read, and then she brought to me and said, would this be appropriate? It was not indexed on like the patient's chart, obviously, but rather just the de-identified like input. But you can certainly ask open evidence to write letters. And again, it's always going to sound confident, and whether it's not going to tell you whether it's accurate or not. But it's an interesting phenomenon because some of the insurances are using AI to write these like denial letters as well. So we kind of are in this place where like the bots are almost fighting with each other. Which is kind of scary when it's like implicating like whether or not your patient can have a procedure or medication. But open evidence what is what I've seen. I haven't seen any embedded tools, but I wonder if that's the next step, is embedded tools like within our EMRs or within the prior authorization like portals.
Thank you for that, and I think that also brings up the important point of keeping the human in the loop, because part of the theme of this entire series is that AI to help clinicians and help in patient care, not to replace clinicians. So it's always important to keep the human in the loop, not only to assess what output you're getting from AI, which may be great and maybe not, but also then to address the issues, as you mentioned, with cognitive offloading, where people tend to start losing their diagnostic skills because they're relying so much on AI that they sort of get out of practice. So it's important as we're engaging with these technologies to make sure that we remain engaged with them and understand what it is that they're doing or not doing, so we can utilize them to optimize patient care and eventually hopefully get to this goal of personalized medicine. So I'd like to thank everyone for attending. Autumn, if you could put the slide up again with the code to get your continuing education credits for this presentation. And I especially would like to thank those that have gone to all of our discussions on the use of AI. And there is the code to get your continuing education credits. And I hope you have a great afternoon. And we hopefully will